Boa noite a todos. Estamos aqui numa nova sessão aqui do Sessão nas terças-feiras, sempre às terças, esse horário, né? Espero que todos possam ter voltado do serviço para poder ouvir. Nessa sessão nossa, teremos hoje com um grande convidado, um professor nato, de uma grande didática, que sempre vimos isso, inclusive em demonstrações ao vivo. E quem também teve experiência de ficar com ele no serviço lá em Orlando, sabe também que ele é um professor muito didático e vai ser muito proveitoso para nossas informações, né? Hoje o tema é erros em aquisição de tecidos durante a ultrassonografia endoscópica e como podemos evitar. Óbvio que várias vezes, no começo da nossa carreira, fazendo a econdoscopia, fazendo a punção, uma das principais funções da econdoscopia é fazer a punção para aquisição de tecido. Isso algumas vezes a gente não tem uma falta de experiência e tem algumas intempéries durante a nossa experiência. Então, eu apresento aqui com grande prazer o professor Robert House aqui para fazer a nossa apresentação e em seguir fazemos as perguntas. Temos também como moderador nosso amigo aqui também o expertise lá em Brasília também, que é o Dr. Bruno Salomão, muito dedicado à econdoscopia e também dos maiores experiências em econdoscopia daquela região do Distrito Federal. Then, Professor Robert House, I'm going to introduce for all the persons, and I ask you to start the lecture, and thank you very much for your kind participation for us. Thank you very much.
Oh, fantastic. Well, thank you very much. It is really a great pleasure for me to be part of this ongoing presentations from the Brazilian Society for Digestive Endoscopy. I have such great friends and colleagues in Brazil. We've been through 2 years of this very difficult COVID. I very much miss the personal interaction with all of you, either in Brazil or here in the United States. And so hopefully this is coming to an end, and I look forward to the day when we can get together and hug each other and resume our close relationships. I do want to thank you, however, for giving me an opportunity to talk about EUS and tissue acquisition, and I hope that my presentation will provide some good information to attendees. The task that I've been given is to talk about mistakes in tissue acquisition during endoscopic ultrasound and how to avoid them. And these are my disclosures. I am a consultant for Olympus, but this really has no bearing on this presentation and really represents no conflict to the information that I will be presenting. I think as a note of introduction, when one is asked to provide or give a presentation of this nature, it sort of asks for you to talk about avoiding complications. Sort of mistakes are equivalent in endoscopy to complications. However, EUS FNA or FNB, as we term it now, is actually a very safe procedure. So I will touch a little bit on complications, but really this presentation will concentrate primarily on reasons for an inadequate sample and then how to avoid that, how to provide a good sample. These are the primary complications for EUS FNA or FNB listed. They include bleeding, perforation, infection, and pancreatitis. And you can see this result of a large systematic review. You can look at the percentage of the percent rate for these complications, and you can see that they're really quite low. And this is fortunate. It's using a small needle and under a good endoscopic guidance, so we would presume that the complications would be low. Nevertheless, there are some complications, And so this slide sort of depicts my primary recommendations for how to avoid each of these complications. I think bleeding comes about primarily because of laceration of intervening blood vessels, predominantly and presumably arteries or arterioles. Those may be and usually are in the gut wall. So avoiding the intervening vessels in the gut wall is a primary method of avoiding bleeding. You can get bleeding within a cyst, for example, and you can also get bleeding within a tumor or a lesion, but those are relatively rare. But the bleeding in the gut wall would be the most common. It's almost never clinically significant in the sense that it requires blood transfusions or hospitalization. And you can avoid this most simply by using Doppler and then altering the trajectory of the needle such that it misses any visible vessel. And if you can do that on a consistent basis, you can generally avoid bleeding. Perforation is unusual, and I think it occurs primarily because of abrupt and fairly forceful lateral movement of the needle when it's across the gut and is in a target lesion. So I think stability of the lesion and stability of the needle trajectory during FNA, I think, is a major way to avoid a perforation. Of course, we're using very, very thin needles, and so there's really no chance of perforation simply from a quick needle puncture across the gut wall. Infection is a very real complication for EUS-FNA. It's predominantly in cysts, and also I've seen it in cases of multiple repeated celiac plexus blocks. In terms of the celiac plexus blocks, I don't know whether there's scarring that occurs and maybe less tissue perfusion in the area of the celiac axis that leads to infection. But for me, to avoid that, I do apply or administer antibiotics, both intraprocedural as well as for a few days after a cyst puncture. And for people that have undergone more than 5 or 6 celiac plexus blocks, I tend to give them antibiotics, though I have no good data to present to you on the necessity of using antibiotics in this clinical context. And finally, there is the issue of pancreatitis. I think this is very rare in cases of pancreatic cancer. However, the axiom or the rule that I use is I never cross more than 1 centimeter of normal pancreas. A classic example would be a neuroendocrine tumor, maybe deep to an otherwise normal pancreas. And so you use maybe a 22 or maybe even a 19 gauge needle in order to get sufficient cells to make a diagnosis. A diagnosis of neuroendocrine tumors can be difficult. And so you use a large bore needle. And if you cross normal pancreas, for me, more than 1 centimeter of normal pancreas, and certainly if you lacerate the main pancreatic duct, then those can be causes for pancreatitis. But in general, that should be avoidable. And so I think my summary is that complications from EUS-FNA and FNB are very rare. And I think there are good mechanisms available to avoid those complications. So I want to move on now to EUS-guided tissue acquisition. And I'll start by saying that, at least in my view, the ideal scenario for EUS-guided tissue acquisition in 2021 is, in fact, to have ROSE, rapid on-site evaluation. So having a a well-qualified cytopathologist making an immediate read on your FNA samples in combination with a sufficient cell block or core to perform molecular staining. So I believe in 2021 that this is the ideal scenario. I realize that this is not a scenario that is possible in all endoscopy units. In fact, it may not even be possible if you look worldwide in the majority of of EUS units. But this is, in fact, the ideal that we should at least strive for or hope for. So the first EUS FNA was performed in 1992, and I think that Villman gets credit for that. Although we performed EUS guided FNA in 1992, around the same time that Peter Villman did, we published that data in 1992. But that is the year of the first EUS FNA. Most of the early studies coming from both Europe as well as the United States, the diagnostic accuracy of EUS FNA was based on ROSE, a rapid on-site evaluation. However, as EUS has expanded, as the number of centers performing EUS-guided tissue acquisition has increased, as Europe and Asia have increased their utilization, the practice has changed. And there are two factors that have caused the change in EUS-guided tissue acquisition. One is that ROSE, that is the presence of a well-qualified cytopathologist making an immediate read on your tissue samples as they're acquired, is not commonly available. Secondly, although originally when we did EUS FNA, we were looking for only a diagnosis of cancer or no cancer. Was it malignant or not malignant? But now it's insufficient to just say that it's malignant. Now we need to have sufficient tissue procured that allows for molecular markers for both diagnosis in some cases and also in some cases for treatment. So these are the factors that have changed the paradigm for EUS-guided tissue acquisition. So it used to be that this is what we looked for, a smear, diff-quick staining, and then an immediate read in the room, and we get a diagnosis of cancer, and we move on. But now we're looking for this, both in the present and looking toward the future. We need greater tissue for greater characterization going forward. So we as endosonographers have to meet that changing paradigm of tissue acquisition. And if you don't, then this is the cause for mistakes made with EUS-guided tissue acquisition. I want to talk for a minute about definitions. These are important when we talk about the samples that we're obtaining. For many, many years, we relied simply on cytology. You obtain the specimen, you smear it on the slide, you stain it, usually with a material called diff-quick, and then the interpretation of individual or small groups of cells is made by the cytopathologist. There is a thing called a cell block. This is a specimen that is expressed into preservative, and the preservative that we use is called cytolite. Then once it gets to the lab, the specimen is centrifuged, creating what I call a tissue pellet. So it's a solid mass of tissue created by the centrifuging. There are various mechanisms of separating and dissolving the blood so that the cell block that you have is left as viable tissue. Fragments, blocks of tissue, as well as individual cells are all impacted into this pellet. That pellet is then embedded in paraffin and stained with H&E, and there may be individual core tissue within this pellet that are available. These are interpreted by a cytopathologist, the cell block is, and an adequate cell block is sufficient to do molecular staining and special stains, etc. And then you have a core. We all have done liver biopsies. That endeavors to get a core, but it's basically a block of tissue that maintains cellular architecture and intracellular architecture. We can obtain a core with EUS-guided FNB. That is immediately put into formalin, but there is a way to express it into formalin in order to maintain this core piece of tissue, which then a histopathologist can then use to make the diagnosis and to do the special stain. So to talk about where we go from here, we have to be speaking in the same language, and this is basically the types of tissue that can be obtained by US FNA, FNB. So when we talk about errors, there are basically, at least in my opinion, there are the 3 T's that can lead to errors in EUS-guided tissue acquisition. One is targeting, one is technique, and the final is tissue handling. And I'll address each one of these sort of individually. So if we talk about targeting, first of all, with targeting, you've got to find the lesion. And this may seem simple, it may seem straightforward, but there are a couple of areas that you need to be particularly concerned about. One is that lesions, particularly small lesions in the neck of the pancreas and in the uncinate process, can be missed. The reason for the miss in the neck of the pancreas is because it is basically at the level of the pylorus. And unless you carefully examine this area, both by pulling back as well as by pushing in, you can miss it. And secondly is the uncinate process. And you can miss the uncinate process if you don't get deep enough within the duodenum. Secondly, lesions can be missed because you just can't find them. And under those circumstances, you should use a CT scan or an MRI to help you find the lesion. Almost always a CT scan or an MRI is available. You should look at and review those cross-sectional imagings that are available. Secondly, in terms of targeting, there can be intervening structures. Blood vessels can be intervening that can make it difficult for you to target the lesion. Other organs can be intervening and around that can confuse you and make it difficult to target the lesion. And then you can never ever FNA a lymph node through a cancer. This will lead to contamination. So if you're targeting a lymph node, you have to find a window in which, if it's a mucosal-based cancer, that you're not going through the cancer to get to the lymph node. So these are my advice, sort of avoiding the errors, so to speak, for each of these conditions. So I mentioned before, in the neck of the pancreas, in the uncinate process, when you're doing the EUS, you should do a very slow, controlled pull from deep in the duodenum. You should follow the aorta. And if you go deep into the duodenum, you pick up the aorta, and then you trace adjacent to the aorta throughout that pull through, then you should adequately visualize the uncinate process. And then some of you don't use a balloon to save money, but if you do use a balloon, I find it helpful to inflate the balloon into the apex of the duodenal bulb and then slowly withdraw to make sure that you don't miss a lesion in the neck of the pancreas. In terms of using the CT scan and MRI, you should find the lesion on the CT scan or MRI and really study the surrounding structures. Look to see if the lesion is in the pancreas, near the spleen, or near the kidney, or near the portal vein, or near the duodenal wall, or near the bile duct, or whatever surrounding structures are near the lesion. This is important to target it. In terms of intervening structures, it's just a recommendation of careful use of Doppler and pulse Doppler to identify arteries and to identify vessels in general that may be intervening between the lesion and the needle. In terms of other organs, just careful imaging and tracing is what I recommend. And then you should have a normal gut wall layers between the transducer and the target. So if you've got thickening of the gastrointestinal wall between the lymph node that you're trying to puncture, then you have to be careful, because that thickening may represent cancer. And many studies have shown that you will contaminate the lymph node. You will not get an accurate reading of lymph node metastases if that needle goes through a tumor. Now we talk about technique. This is most of the studies done in terms of getting adequate tissue have done on technique. I will readily admit that many of the studies are conflicting. I think that technique is a very personal issue. As I've traveled around the world and I talk to people, they seem to be biased very strongly by the technique that they've learned and acquired over time. And I feel that people are oftentimes not very receptive to studies that show that it may be a different technique yields better tissue. But nevertheless, we have to stay with data. I mean, that's the only way that we can objectively discuss things. Unless a study has been done and the methods are outlined in terms of the technique, it's really difficult for us to have a meaningful discussion. So in terms of the technique, there is needle selection, which involves the gauge of the needle and the bevel of the needle. And then there's the needle puncture itself, and there's a technique called fanning, and then a technique of suction. In terms of needle selection, it is now 22 gauge has become the standard. If the only thing that you need to know is whether it is malignant or not malignant, then you can use a 25 gauge needle. But I will show you some data in a minute that indicates that at least in 2021, with molecular studies being performed on the tissue samples, that a 25 gauge needle is inadequate. We will also talk about the bevel, and I'll show you data to suggest that you should be using either the Francine tip needle or the fork tip needle in 2021. And then in terms of needle puncture, I'll talk about fanning and suction. So these are the various needles that are available to you. This was the standard for many, many, many years, the standard bevel. We do have some variations. The Procore needle has this side port with a cutting edge to it. The Olympus needle has a Mangini type tip, as well as a side hole to it. The Sharp Core needle has this specialized fork tip, what we call a fork tip to us. And then the Acquire needle from Boston Scientific has this conformation to the end of the needle. But these are the needles that at least are currently available for acquiring tissue. And I hope at the end of this talk that to avoid errors in tissue acquisition, we should be leaning strongly on these new style bevel needles from Medtronic and from BSC. So this is a study that we did here in Orlando, looking at the gauge of the needle and what is optimal for FNA. During this study, we looked at the 22 and the 25 gauge needle. We also studied suction versus no suction. And I'm not going to go into this because this is sort of not completely relevant because it was using the standard bevel needle. But the bottom line is that you can see here, this is not about diagnostic accuracy. This is about a cell block. This is about getting a cell block that is not only supports the diagnosis or makes the diagnosis, but allows for molecular staining. And you can see here that the 25 gauge needle, whether you use suction or no suction, really had an inadequate diagnostic cell block. And even the 22 gauge with suction had only a 71.5% adequacy in terms of the diagnostic cell block, with the 22 gauge and no suction being the best. I would highlight here that the overall diagnostic accuracy, no matter what technique you used, was exceedingly high. So for diagnosis, at least, if you use good standard technique, we should be getting a diagnosis in the great majority of cases in 2021. This is a randomized trial that we did using the Francine needle, this needle from Boston Scientific called the Acquire, and the standard bevel needle. And I highlight again, the diagnostic adequacy was high in both of them. But if you look at the cell block diagnostic adequacy, it was 98% for FNB, but only 82% for FNA. So a significant diagnostic adequacy, a significant difference in terms of diagnostic adequacy. So again, the diagnostic adequacy was far superior for the FNB needle as opposed to the standard bevel needle. We looked in this study at very sophisticated ways of looking at the adequacy of the tissue, the total tissue area, the tumor area, the desmoplastic fibrosis, et cetera, et cetera. And you can see here again, when you really look at the quality and volume of the tissue obtained, there was a significant benefit for the FNB needle over the standard bevel needle. So this is what leads me to recommend, again, in 2021, to avoid inadequate samples that you use FNB needles. This is another study that we did looking again at technique that was fanning versus no fanning for pancreatic masses. And again, the diagnostic accuracy was much superior for fanning versus a non-fanning technique of just passing in and out in one standard trajectory. So we feel very strongly about this fanning technique. And basically, if my fist is the tumor, then what we recommend is various trajectories of the needle through the tumor. So you go in this direction, and then this direction, then this direction, and this direction, and you go from one side of the tumor to the other side of the tumor. That's what we describe as the fanning technique. Again, we looked at suction versus no suction, and the diagnostic accuracy is good. In terms of suction versus no suction, in terms of an adequate volume of tissue, suction versus no suction is about the same. The big problem with suction is if you happen to have rows in your unit. So if you do have a cytopathologist that is coming to your room, you're plating out the specimen and looking at it immediately underneath the microscope. In general, suction increases the amount of blood, and blood is not so problematic for a cell block or for a core, but it is difficult for an in-room evaluation because of the dilution from the blood. So in general, we recommend no suction because it produces less blood and you get a similar adequacy in terms of the volume of tissue. And finally, there is the issue of tissue handling, and this has maybe not been emphasized enough, but it can be a real issue that can affect your tissue acquisition and can lead to errors in terms of getting adequate tissue. If you happen to use rows, you basically express the slide, express the specimen onto the slide, but the key here is to use a stylet. So we don't use a syringe and forcefully blow the specimen onto the slide. We use a stylet so that we can gradually advance the specimen onto the slide, and then as soon as there's enough tissue on the slide, then we put the rest in a controlled manner into the cytolite or preservative. We then smear the specimen in the room, and as I mentioned earlier, if you're going to do rows, do not use suction. It just adds to the bloodiness of the specimen and will make it more difficult for the cytopathologist to get a critical number of malignant cells to make a call. And then whatever extra specimen is put into cytolite, and then if you're endeavor to get a core, you can put it directly into formalin. So this is the method of tissue handling. If you have a cytopathologist in your hospital, not necessarily just in the room, but if you have one in the hospital, then the general recommendation, if the cytopathologist will read the specimen immediately, then please do rows and then put the specimen in cell block, and that will be read by the cytopathologist. If you do not have a cytopathologist, then you should endeavor to get core tissue. That should be expressed directly into formalin and then read by the cytopathologist. If you have no cytopathology, then you should be using the bigger needles. So don't use a 25 gauge needle, use a 22, 20, or 19 gauge needle. And you should be using an FNB needle to get adequate tissue. You should do fanning. You should do a limited number of thrusts and withdrawals. So don't go through the same trajectory multiple times. And you can use suction or no suction as you would want. You express it into formalin, okay? But this is very important. If you're trying to get a core piece of tissue, it should be expressed with a stylet, and the stylet should be advanced, particularly as it gets toward the end of the needle. The stylet should be passed very slowly at the end of the needle. If you just go as fast as you possibly can, that will fragment the tissue. Whereas if you go slowly and slowly deposit it into the formalin, then you are more likely to get these long core pieces of tissue that are particularly important for liver biopsy, but are also important for other tissue evaluation as well. You should visually inspect the quote unquote worms, and we're really looking for pale sections within the worm. Those parts being very deep red typically are blood, but good tissue typically is pale. And then, of course, you can't do this with very small lesions. A 3 millimeter lymph node, you can't get core tissue on. So really, you have to do cytology if you're going to go for a very, very, very small lesion. What sample is adequate for molecular staining? The last thing in the world that you want to do is put a patient through EUS-guided FNA or FNB, and then deliver the sample. The cytopathologist reads it as cancer, but then your oncologist says, well, we need this staining, that staining, this staining, and that staining. And then they look at the specimen and they say, we're sorry, there's insufficient tissue to do these stains. That, in 2021, in my view at least, is the predominant error, if you will, for EUS-guided tissue acquisition. So if it's a cell block, that's fine. You obtain the specimen, put it in Cytolite, they'll spin it, etc. But an adequate cell block does have sufficient volume of viable cancer cells to do molecular staining. And obviously a core, a true core, also has enough specimen to do this molecular staining. There are some circumstances probably in which a core, i.e. using a biopsy needle of at least 22 gauge in size, where a core specimen is really needed. Those include liver biopsy, maybe lymphoma, maybe GIST, and then maybe autoimmune pancreatitis versus cancer. So these are particular areas where probably you want to go after a core. And again, to do an FNA on somebody with suspected lymphoma and get inadequate sample to do the stains and studies necessary to characterize that lymphoma is definitely an error in tissue acquisition. So the take-home points from a technique standpoint is do fanning, no suction with rows, slow pull or wet suction I think needs more study. Use a 22 gauge FNB needle. Volume of tissue is critical. Match the EUS tissue acquisition to the pathology service, whether you've got a good cytopathologist or you only have a histopathologist. And as I say, optimal situation in 2021 is in fact to have rows, to use fanning, and to use an FNB needle. So with that, I'll close and open up for discussion. This is my new hospital in Orlando. I have switched and I'm with a new healthcare system called Orlando Health. And from this picture, if you look off to the left, you will see going up and opening in January will be a new Digestive Health Institute. These are the four of us, Dr. Bang, Dr. Navanethan, Dr. Varadarajulu, and myself, who are leading the effort to develop this Digestive Health Institute. And I hope once COVID passes and movement is back to being free, that all of you will take an opportunity to come and see our unit and visit with us, and we can reinvigorate and reinitiate very deep friendships with my Brazilian colleagues. So with that, I'll stop and be delighted to open this up for discussion. But thank you very much for the opportunity to be with you this evening. Thank you.
Thank you very much, Professor, for your complete and great presentation. For us, I think that I'm sure that a lot of echo-endoscopists here in Brazil were interested in your presentation, in your information, your take-home messages. And I think that Bruno is going to start with the questions. We are going to wait for the questions of the audience. Bruno?
Well, congratulations, Dr. Robert, for your amazing presentation. I'm sure everybody learned a lot with this in this last 30 minutes with you. Of course, there are some doubts and no consensus in the type of the needle, the size of the needle, the way of doing the punction. And I'd like to start talking about subepithelial lesions. From which size of the you punction a subepithelial lesion? Do you
what type of lesion?
From what size of subepithelial lesion do you punction?
For the subepithelial lesions.
Yeah, talking about subepithelial lesions.
Subepithelial lesions.
Yes.
Yeah. So I use a 22 gauge FNB needle because it is adequate for getting the molecular stains, and it is easier to puncture. Oftentimes the subepithelial lesions can be mobile, and I find a 19 gauge needle oftentimes to be difficult to pass through the lesion and also to get the lesion punctured because of its mobility. So my favorite needle would be an FNB needle, either the Shark Core or the Acquire, and I would use a 22 gauge needle, and obviously I'm endeavoring to get a adequate cell block or a core.
And what size of the lesion do you consider to puncture?
Very good question. So in general, most of the subepithelial lesions are stromal cell tumors, and my cutoff for doing FNA is 2 centimeters.
Okay.
But that varies. So if it's in a very, very easy location in the greater curve of the stomach, if it's 2.5 centimeters, if I follow it over time and it's growing, or it has some worrisome features to it, then I might not do a puncture just because I've already made the decision to remove it. But in general, 2 centimeters for me, if I think that it's a stromal cell tumor, is a cutoff in doing so. I'm still old school with regards to the esophagus, meaning that my thoracic surgeons complained that if they had to go in and enucleate an esophageal stromal cell tumor, that if it was tacked to the esophageal mucosa, that it could make it difficult to do an extra esophageal enucleation. They might tear the mucosa. So I'm more conservative with the esophageal lesions. They're more likely to be a leiomyoma. And if they do not cause dysphagia, then I typically don't FNA them.
Okay, Professor. In our practice, we use the 22 gauge needles for diagnostic, generally, mainly, and 19 gig for therapy, for therapeutics. And in your opinion, is there a space for the 25 gauge needle when you use the 25 gauge needle?
Yeah, good question.
And another is there is a difference. Is there any kind of difference between FNA and FNB if it's 25?
Right. So I think the best way to think about it is that if all you need is cytology, that's all you need. And particularly if you have rows, then I think a 25 gauge needle is adequate. It's not adequate to get enough volume of tissue to do tissue staining. But for instance, you've got a lung cancer. It's already biopsied. You've got a lung cancer, and you're doing an FNA of a mediastinal lymph node, particularly a small mediastinal lymph node. All you want to know is there cancer cells in that lymph node, or there are no cancer cells in the lymph node. Then this would be a good indication for a 25 gauge needle. There's almost no complications from it. It gets an adequate sample to detect whether there's cancer there or not, which is all the information that you need. I think also if things are in a very, very difficult position, I'm near like a critical vessel, if I'm near the pulmonary artery or near the heart or near a moving target, and I really want to be as safe as possible, or I'm crossing the pleural space or something like that, then those are reasons that I will go to a small gauge needle, realizing that the best I can do is there cancer or is there no cancer, and not generally able to do molecular staining.
Dr. Robert, there is a question from the audience, from Dr. Victor from Belo Horizonte, Victor Arantes.
Hi, Victor.
He's asking a practical question. If there is a nodule in the head of the pancreas and you have the interposition of the gastroduodenal artery, it's safe to puncture through the artery.
Yeah.
What is your experience puncturing through vessels?
Yeah, so I haven't done it very often. My colleague has done a few FNAs through the aorta. Of course, I have lacerated arteries and gotten intramural bleeding and so forth. But again, I'm sort of old school. I would tend to use a smaller gauge needle. I would try to bend that needle to avoid going through the gastroduodenal artery. And then I look at the indication. Is this just absolutely critical to do? And then also it depends on sort of what I think is at the end. As an example, if I had something that I thought was likely chronic pancreatitis, but I wasn't quite sure, or I thought it was maybe autoimmune pancreatitis and I wasn't quite sure, and I'm going to have to go straight through the gastroduodenal artery, I probably would not do that, because I know that to differentiate between chronic pancreatitis or autoimmune pancreatitis and cancer, I'm going to need a really robust sample, which usually means multiple samples with a large needle. So I think it just all depends. If going through the gastroduodenal artery is an absolute must, it's critical to the patient, all the doctors caring for the patient say you've got to do this, then I might very well do it, but I would do it with a 25 gauge needle, and then I would demand that a cytopathologist is in the room so that I can do one pass, and then if that's positive, I can stop. I wouldn't want to be a situation where nobody's looking at it and I just have to keep doing passes because I don't really know if the first pass was adequate. So I think it's not a straightforward answer.
Sure.
But I in general, I think it's best to avoid arteries.
Professor, what about the esophageal cystic duplications?
Yeah.
If you have doubt about the diagnosis, do you think that we have some strategy for the puncture to avoid the infection? You are afraid of infection? What do you think about this?
That's a great question, and maybe something I should have incorporated into the talk. I am very concerned about mediastinal cysts, and I published a very small series, only 6 patients with mediastinal cysts, and we infected 5 out of the 6. And so I'm very, 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 very reluctant to puncture a mediastinal cyst. I think the other part is that the puncture is usually non-diagnostic. It's not like a cancer where the cells, you see they're malignant. You get debris, maybe you get some mucin, maybe you get some epithelial cells, but seldom does the aspirate give you the diagnosis. And so I'm very reluctant to do so. I have made a mistake before. I've seen sort of suspended echoes within it. I thought that it was solid. I punctured it. It turned out not to be solid. And then, of course, I stopped. I do give those patients antibiotics if I do the puncture. One should consider at least giving antifungal agents if it's through the esophagus. But in general, my recommendation to the audience is to avoid it.
Okay. Another question from the audience, from Umberto, from Rio.
Yes.
In cases of pancreatic lesions with stent or plastic stents or metallic stents, do you have any trick for puncturing a lesion drained?
Yeah, so I think the metal stents to me are more difficult. There is air artifact. The only recommendation I can make is to go beside it, to find sort of tumor and areas beside the stent and to puncture it there, not to go in and out of the stent, but to puncture beside it. Look for the greatest distance of hypoechoic tissue and then go beside the stent. I think it's a little bit easier for plastic stents for me, at least than metal stents. Studies, however, one study was done by my partner, Dr. Veeradarajulu, who suggested that there was no difference in the accuracy of doing a pancreatic head lesion with or without a stent in place. The most difficult, however, is not the pancreatic mass, but it's cholangiocarcinoma. I find trying to get cholangiocarcinoma once a stent is in place really to be very, very, very difficult, partly because they're less cellular tumors. But I think in there, a stent can make it very, very difficult.
Professor, Dr. Marcelo from São Paulo asks you what's your opinion about the wet suction?
Wet suction, yeah.
Yes.
So I don't use it routinely. We've not studied it. And so I mentioned earlier that there is a lot of bias. A lot of people have a lot of experience and they rely on that experience. And so I can't really comment on it because I haven't studied it. So I think that my advice would be, number one, I think it requires more study. So if you're using it, I would encourage you to do a study to show all of us that we should be using it or not using it. I understand that there are theoretical advantages, but I haven't seen enough data to make it a part of my routine practice.
Okay.
Another question from the audience. For suspected metastatic lymph nodes from cholangiocarcinoma with no mass effect, would you recommend 22 FNA or FNB? And specify if there is difference from resecable versus unresecable lesions.
Yeah, so again, lymph nodes to me are a little bit different. A lot of the studies that we did with like the Francine and the regular bevel needle were done with pancreatic masses. In lymph nodes, in general, you just want to know, is there cancer or no cancer? Usually it's a metastasis. Obviously, the one exception being lymphoma. Lymphoma is a little bit different. But if I got a patient with cholangiocarcinoma, I see some hilar lymph nodes, I don't know that it really matters too much because the diagnostic accuracy of an FNB and FNA are fairly similar for just diagnosing cancer or no cancer. And I think that in terms of the gauge needle, as I said before, I think if I'm having to dodge blood vessels and it's a very, very difficult location, I tend to use a 25 gauge needle. But if it's a straight shot and it's easy to get at, then I think a 22 gauge needle in general gives you more specimen.
And Professor, are you concerned about the risk of bleeding major in F&B punctions?
Yeah, so that's a really good point. There's been no study that I'm aware of looking at clinically significant bleeding in which there's a difference between the FNB and the FNA needle. My bias, I have no data, but my bias is that the fork tip and the Francine tip are more apt if you've got a blood vessel in your trajectory, that a fork tip or the Francine has a greater chance of lacerating that vessel than does a standard bevel needle, which I think oftentimes will just pass right beside it. So there's no study to show that, but this is totally my opinion. But if you were dealing with somebody with varices, there were a lot of intervening vessels, then I would consider using a standard bevel needle. Just my own personal recollection is that, you know, everybody occasionally gets the spurter from the mucosa after you do FNA or FNB. In my own personal opinion, I get more bleeding from the biopsy needles, but that's purely my own experience, and I don't have good data to drive that discussion.
And Professor, nowadays, do you think that it is available for us to performing a punction of a lesion in the right column or the cecum? What do you think about this? Yeah.
So, you know, we do FNA in the rectum all the time. For lymph nodes or whatever, I think crossing the rectum, I've seen no study to show any problem with infection. I think putting a needle through the colon into the peritoneal cavity, to me, is a little bit different. I think we just haven't done it enough, and there's certainly no randomized trial. And I think that it's one of those things that it just depends on the circumstance. If there was I don't know, maybe somebody with gynecologic, like ovarian cancer, and there was an implant clearly on the wall of the cecum, so that I was going through the colonic wall, but I was going directly into a mass, and this was going to make a significant difference for the patient, and there wasn't any other or better way to get the tissue. Then if I could get my linear scope around and could do that, then I would do that. So going directly from the colon into a solid mass, I would be okay with. But going through the colon, going across the peritoneal cavity into something that's in the peritoneal cavity, to my view, that's too risky.
Doctor, I think we have time for one last question. Talking about cystic lesions of pancreas,
yes.
What would you think is the best way for performing the punction and to get tissue off the wall? Do you have experience with this biopsy needles? What is the best way to do it, in your opinion?
For me, the short answer is that if I need to get tissue, I think in 2021 that the biopsy is the best way to go. It is not without potential complications. It's not without issues. But if I had just one way to get tissue from a pancreatic cyst, my preference would be to use the biopsies. That's my short answer to that.
I think it is 2 hours. And thank you very much, Professor, for your kind, excellent, amazing presentation for us. I'm sure that it's going to improve a lot for us, for Brazilian echoendoscopies. And I hope that we can meet together and to in Brazil, here in Brazil also, in another time. Thank you very much thank for all folks.
Thank you all for the very kind invitation. It's wonderful to see you, even though it's virtual, and I echo those sentiments. I hope that we can gather in person together, either here in the United States or in Brazil in the near future. And in the meantime, please, everybody stay safe and stay well. But thank you so much for welcoming me into your group. Thank you.
Okay.
Thank you, Professor.
Thank you.
Take care.
Bye. Ciao. Ciao, ciao.
Ciao.